Everybody, good afternoon. I'm Senani, registrar in ITU. I'm going to talk about sepsis and septic shock today. So here I will be talking about the newest explanations of sepsis, septic shock, its basic pathophysiology, and ITU management of septic shock, and bit of regarding antibiotic stewardship. So with this, I may ask me to put a scenario. So this patient actually I met 3 weeks ago in A&E. He was 65-year-old male nurse with a history of hypertension and hyperlipidemia, uh, which were well controlled. He was only on amlodipine. He was fit and well patient. Only he presented to the A&E with a history of tested positive for COVID for 1 week duration. Then he had diarrhea, vomiting, poor oral intake, and low urine output for 3 days duration. So when he come to A&E, he was maintaining his airway. He was he was not any respiratory distress. There was no audible other added sounds, but the saturations were unrecordable. We did a HS X-ray. There was no significant changes, and he was having acidosis in the blood gas. Oxygenation was maintaining in the according to the blood gas analysis, but saturation was unrecordable really. The bicarbonate level was around 12, lactate was around also 12. These are actually not the real things that, as I remember, I put these blood gas, but this is close to the normal values really. Then his hemodynamics, heart rate was 95, blood pressure slightly low, MAP was maintaining around 55. Capillary filling times was so prolonged. He was severely mottled and cold clammy peripheries were there. He was having good GCS, glucose were normal. In exposure, no rashes were there, and temperature was 35.6. He was really hypothermic. Investigations wise, he had a high WBC and high CRP values. So in the A&E, we were very aggressively treated him because we were very worried about his basic functions and hemodynamic status and the blood gas analysis. So we had applied basic monitoring ECG, NIBP saturation. High flow oxygen was started via non-rebreathing mask and inserted 2 cannulas. Cannulations was so difficult, but we managed to do 2 cannulas, and then started aggressive fluid resuscitation with crystalloids, and his legs were put upside to maintain the venous return, improve venous return, and we took blood cultures to aerobic and anaerobic cultures and started broad spectrum antibiotics, coamoxiclav, amikacin, and clarithromycin given after the blood cultures. So meanwhile, resuscitating the patient with crystalloid aggressively, we inserted invasive lines, arterial line, CVP, femoral and vascular femoral, and also started noradrenaline infusion to pick up blood pressure. We repeated blood gases to check his lactate levels, and we found that potassium and calcium was low. It was meanwhile corrected. So actually with these treatments, after around 2 to 3 hours time, his hemodynamics became normal. He was clinically, subjectively telling that he was feeling better. But anyway, for the further management, we expected him to maybe need renal replacement therapy. So we admitted anyway for the observation and everything to more improve his parameters. I couldn't follow up the patient, but we did these things very quickly. So because of that, he when he was admitted to the ICU, he was in a good stable condition. So as we all know, sepsis and septic shock are very common and it's a major healthcare problem, impacting millions of people around the world each year and killing between 1 in 3 and 1 in 6 people who affects it. So over the past decades, that Surviving Sepsis Guide campaign has improved their guidelines by uh, analyzing with their randomized controlled trials, and various guidelines have been developed. But latest guidelines are in 2016 and 2021 to manage the sepsis and septic shock. So according to their latest guidelines, they tell sepsis is now defined as the life-threatening organ dysfunction caused by dysregulated host response to infection. So septic shock is a subset of sepsis in which underlying circulatory and cellular dysfunction associated with higher risk of mortality. In septic shock, patients are usually having persistent hypertension, requiring vasopressors to maintain MAP more than or equal to 65. Lactate is greater than or equal to 2. So, how are we going to screen the patients with sepsis or septic shock? Actually, earlier in the Surviving Sepsis guidelines, they thought that Q-SOFA and SOFA scores are more better to screen the people with patients with sepsis and septic shock. But now they are against just using the Q-SOFA or SOFA to identify or screening the patients, but they, in compared with the SIRS, NEWS, or MEWS criteria as a single screening technique. So now they recommend hospital systems should have a performance improvement program for sepsis and including sepsis screening for acutely ill high-risk patients. So if I tell you what is the Q so far, they were telling they were having a screening method earlier. Q so far is a quick sequential organ failure assessment score. There are three elements. The one is altered mental status. Second one, respiratory rate greater than or equal 22 minutes per breaths per minute, and systolic blood pressure less than or equal to 100 mercury millimeter. If any of patient having two out of more than two criteria of these, they suggest that the patient has high risk of developing uh, hospital admission and mortality, and also ICU admissions. Uh, the other thing is a more complicated SOFA score. It's a organ failure assessment score which contain systems like respiration, coagulation, liver, cardiovascular, central nervous system, and renal. So they categorized to according to the parameters, and if we take a baseline score, if any patient is rising in two values in the score, they are telling the patient has a high risk of going into organ failure. So as I told you that actually we have to have all the parameters, vital parameters, news, MEWS, and also the QSOFA, SOFA, all the systems or whatever the which is good, appropriate for hospital system, our individual hospital protocols should be have to screening of patient other than having one uh, screening method. So if you come into the pathophysiology of sepsis, it's a very complex process that when it's an inflammatory disease condition, sepsis, and it going to activate the innate immune system of the host. So if one of a bacteria, virus, or any fungus pathogen bind into receptors like toll-like receptors, not like receptors, these going to induce a complex intracellular signaling system. Then it lead to expression of several common gene classes, going to evoke inflammation, adaptive immunity, and cellular metabolism. Uh, this led to recruitment of pro-inflammatory intermediates such as tumor necrosis factor, interleukins, and interferons. And these cytokines initiate a cascade of other inflammatory cytokines and chemokines, which lead to ultimately transition of endothelium from an anticoagulant state to procoagulant state, leading to the loss of endothelial tight junctions and increased intravascular uh, permeability, and also damage to the endothelial glycocalyx. So endothelial glycocalyx is a subendothelial glycoprotein layer which have a barrier between the cells and the bloodstream. So more they have the barrier is breached. So there's going to more inflammation and leakage of uh, leakage. So ultimately, the complement activation lead to several complements like C5A. These are responsible for the amplifying inflammatory cascade, vasodilation, tissue damage, DIC, cardiomyopathy, and multi-organ failure. So the patient ultimately develop immunosuppressive state and inflammation, widespread inflammation. So have high risk of developing other infections as well. So management, the management is has to be carried out very aggressively in appropriate manner. It's a priority. So the treatment is based on three components such as infection control, hemodynamic stabilization, and modulation of the septic response. So earlier the surviving sepsis campaign guideline had earlier plan of management like bundles which come in 3-hour bundle and 6-hour bundle. Initial 3 hour you have to take blood culture, measure blood lactate level, take blood cultures and antibiotics. Then if fluid resuscitation, then the next 6 hours. If the blood pressures are still low, going for the vasopressors, like they had initially separate two bundles, but now they're telling they have come all together, taken these valuable thing together, and they are telling 1 hour, within 1 hour they have to do these things to optimize the patient's outcome according to their past researchers. So initially we have to, according to that, we have to check measure lactate level. If the lactate are high, more than 2, we have to reassess the lactate after fluid resuscitation. So then take blood cultures prior to administration of antibiotics, then administer broad spectrum antibiotics, and begin rapid administration of 30 ml per kilogram crystallide for hypertension or lactate more than 4 millimole per liter. Then apply vasopressors if patient is hypertensive during or after fluid resuscitation to maintain MAP more than 65. If they recommend now, even if the patient does not having invasive lines, to start vasopressors from the peripheral line until we have inserted the invasive line. Then the antibiotic steward. If I talk about the antibiotic stewardship generally, it is it incorporates that the rapid identification and treatment of infections based on the pharmacokinetic and thermodynamic properties avoiding the use of unnecessary broad spectrum antibiotics and shortening the duration of administration and minimizing the number of patients receiving unnecessary antibiotics. This is basically the what is the antibiotic stewardship. Here, in regarding sepsis, the recommendation for the antibiotic in sepsis and septic shock, they mainly uh, recommend to start broad spectrum antibiotic therapy, which will cover all possible organisms based on the likely source of infection, local microbiological flora, and resistant patterns. And they prefer to start a combination of antibiotic microbial treatment over single agent therapy. Once we receive cultures, then we have to choice the antimicrobial should re-evaluation should be done, and de-escalation should be done to narrower spectrum earlier. And also they tell to start antibiotics within 1 hour of recognition of the sepsis. And when we are suspecting high risk of multi-drug organisms, pathogens, they suggest to start 2 microbials, antimicrobials with gram-negative coverage for empiric treatment over 1 gram-negative agents. And also, we have to optimize the dosing strategies of antimicrobials based on accepted pharmacokinetic, pharmacodynamic principles and specific drug properties. So, if the patient in CRRT or patient having a renal failure, we have to adjust our drug dosing, and also daily drug monitoring. We can check blood levels of antibiotics to optimize the therapy. Next, very important part is the source control in the sepsis, septic shock, because that has shown that if earlier we come to look for a source of infection and source control according to medically and logistically practical. Earlier, within 6 to 12 hours, if we can carry out the source control, like doing laparotomy or whatever, abscess drainage, that would have a more better outcome of the patient. So if the patient having any intravascular access device which we suspect with any sepsis, we should earlier remove that devices and reinsert new one. That will also improve the patient's conditions. So daily assessment for de-escalation of antimicrobial should be done, and we have to use shorter duration of antimicrobial therapy over longer duration. If we have unclear about the duration of antimicrobial therapy, then we have to use the procalcitonin and also clinical evaluation to decide when to discontinue the antimicrobials over clinical evaluation or alone. That means we have to combine procalcitonin and the clinical evaluation to decide on the duration. So fluid management is so important because to maintain the organ perfusion, preventing further shock and organ injury, we have to fluid resuscitate the patient earlier and rationally. So it can be considered in 4 phases. It's salvage phase, optimization, stabilization, and de-escalation. So if we discuss slowly about that, the fluid administration will depend on the phase of shock. Earlier salvage phase of the treatment, we should generously administer fluid before obtaining monitoring. Then in the optimization phase, we have to individualize therapy of fluid resuscitation with monitoring of fluid responsiveness with passive leg trace testing with the fluid bolus. And they encourage to use dynamic measures like stroke volume variation, pulse pressure variation, or echocardiography. Those are dynamic measures to evaluate fluid resuscitation, uh, or physical examination like central venous pressure, like static parameters. We have to combine other physical things and these dynamic measures to check the individualized requirement or optimization of the fluid status. Then comes the stabilization period, the ultimately de-escalation phase. In that phase, we have given a lot of fluids, so we should plan for the negative fluid balance ultimately. So, in this fluid resuscitation, basically we are targeting MAP more than 65. We have to earlier, possibly we have to go for invasive lines in intra-arterial blood pressure monitoring, because it gives a more rational and optimal blood pressures, and also central venous pressure CVP lines to fluid resuscitation, and also the vasopressor administration. And regularly we have to, while we giving fluids, we have to check the lactate level, so that 30 ml per kilogram bolus is also not the for every patient. We have to clinically judge the patient's parameters and the targets we are achieving. So we have to decide on what amount of fluid needed for this patient according to his or her condition. So fluid therapy. Ballast steroid solutions are the fluid they encourage to resuscitate patients initially, and also the replacement subsequently. Using albumin initially, they are not happy about that. They want, if the we with the fluid ballast crystal solution also we can't replace, or we can't fulfill our targets. In that case, the albumin targets they planning for more than 30 gram per liter, like with replacement of 20% albumin. But it's not the first line, only very in the ultimate phase. So hydroxyethyl starches also they have banned from using, because it has shown that their mortality is increased with the use of hydroxyethyl starches in sepsis. So they ultimately, if the patients with fluids are resuscitation, being resuscitated, still the patient needing, still the blood pressures are, we are not happy, we haven't achieved the our targets. In that case, we have to think about vasopressors. So the first choice of vasopressor they are suggesting is the norepinephrine. It is having a more potent alpha 1 action, and so it's act on beta 1 receptors also, but with having more potent alpha 1 effect, it will vasoconstrict and increase the MAP with the minimal effects on heart rate. If it's with the norepinephrine, if it's going up more than 0.25 to 0.5 mics per kg per minute, then they are suggesting to add vasopressin. It is a V1 receptor agonist, which will vascular smooth muscles are constricted, and it will improve the arterial blood pressure, and it will reduce the noradrenaline requirement as well. The next they are telling to start, if still the blood pressures are not adequately maintained, like refractory shock, so then we have to think about epinephrine, which has alpha 1, beta 1, beta 2 receptor action, having more beta effects, beta 1 effects that will cause tachycardia more. So, if with the fluid resuscitation, vasopressors, we have come to blood maintenance, blood pressure, volume also replaced, but still the patient having persistent hypoperfusion with hyperlactemia and poor oxygenation. In that case, they suggest to start dobutamine. So it will contract the heart more, and it will increase the cardiac output, and we improve the oxygenation, and will improve the hyperperfusion in the ultimately. So these vasopressors according has been improved the patient's short-term mortality according to their studies. Uh, if the patient is having high, as I say, with the fluid vasopressors in needing in increasing your requirement, so the hydrocortisone have a place in that case. With a moderate dose of hydrocortisone, IV hydrocortisone, 200 milligram per day, they have seen that good benefits, survival benefits in severe sepsis and septic shock with so the hydrocortisone actually will act as a um, vast act against the widespread inflammatory reaction which is occurring in the body. So that has a good response, helping to the body to respond against the septic shock uh, in better way. So it has shown the length of mechanical ventilation and ICU stay also has reduced with the use of hydrocortisone also. So the ultimately the with the patients, this is a sepsis and septic shock, actually a multi-organ dysfunction leading to every system involvement. So respiratory system also going to succumb to this condition. So they usually develop ARDS like presentation, uh, leading to poor oxygenation and poor carbon dioxide removal. So in that case, they suggest to start ventilation, mechanical ventilation. There is a ARDS net protocol. We can follow that. So basically, they recommend for low tidal volume ventilation strategy or high tidal volume step strategy around 6 ml per kilogram per weight, that to prevent the normal lung tissue. And also they are telling to target lower plateau pressure, targeting 30 mercury 30 water centimeter over higher plateau pressures to prevent the normal lung, and also higher PEEP over lower PEEP for ventilator strategies. If the patient with this using these techniques also, if the patient is still not maintaining his adequate oxygenation, in that case we can target for prone ventilation over 12 hours daily. And in patients, we use our ventilated patient neuromuscular blockers, but they suggest to use intermittent neuromuscular blocking agents over continuous infusion. So other than the taking basic ventilation, cardiovascular, and antibiotic, everything, other than that, we have to think about these other measures as well. Like if the patient is high risk having stress ulcers, we have to start stress ulcer prophylaxis and think about venous thromboprophylaxis. And if the patient is having acute kidney injury, so start of continuous or intermittent renal replacement therapy. If the blood sugars are more than 10 millimole per liter, to start of the insulin therapy, and also starting early enteral in nutrition also they suggested if there is no other contraindication. Uh, so, although still there is no long-term mortality or quality of life, we little know about any long-term effects of the patients who undergone had septic shock and sepsis. So even it is less to identify the functional and cognitive recovery after sepsis. So only a very minority of patients return to functional lifestyle. So this is my presentation and these are my references. Uh, Thank you very much, everybody. Hello, Amaya.
Hi.